to our ongoing program. This evening's Gray Anatomy is on memory loss and fine motor skills. And as usual, it will be, we will do a video of it so that you can go back with, if you need any references to it, on the library's YouTube channel. But that will be done in the speaker view, so you will not be on it unless you're talking. So you generally will not be on it. We would appreciate it. Any questions you would put in the chat, which is at the bottom of your screen if you open that up, and ask any questions, and Kathleen or I will pass those on to the doctor during his presentation. So at this point, I'm going to turn this over to our good friend from LMH, Allison Coons, who will introduce our speaker for the evening.
All right. Thank you so much. Thank you for attending Gray's Anatomy. It's a really fun series to be a part of. So thank you all for participating. So tonight, I would like to introduce our speaker, Dr. Kumar. Dr. Kumar received his medical degree from Patna Medical College in India. He completed an internal medicine internship at Roger Williams Medical Center in Providence, Rhode Island, and a 3-year neurology residency with Seton Hall University at JFK Medical Center, New Jersey Neuroscience Institute. Pardon me. He completed fellowships in clinical neurophysiology at the University of Kansas Medical Center and has an interest in treating patients with movement disorders. Dr. Kumar is board certified in neurology and clinical neurophysiology. So with that, I'm going to turn it over to you, Dr. Kumar.
All right. Good afternoon. Can you guys hear me?
Yes.
Yes.
Okay. So, well, welcome everybody. I was told to talk about memory loss and motor deficits, but we can do memory loss, mainly motor deficits we can touch on. So basically, when we say memory loss, what do we mean? What are the types of memory? Well, mostly when we are looking at a disease, we are thinking of two big categories. Is it short-term memory, long-term? Short-term as an immediate, few days, few weeks, long-term as far away. But there are other types of memory, and then you can go into the nuances of these things. For example, there is something called working memory. You remember stuff for short-term. Okay, where did I park my car? How much money do I need to pay at the register? Or it can be episodic memory, recalling recent events. Or it can be semantic memory, recalling words. Very common complaint. I don't remember names. I don't remember words. It can be prospective memory, which is recalling things like appointments. So, a patient will say, I don't remember appointments. So there are many types of memory we'll look at, different types of memories are affected by different types of diseases. We'll mainly focus here on Alzheimer's. Recently, you must have heard about Bruce Willis being diagnosed with frontotemporal dementia, right? This week we learned about it. A little bit about quote unquote chronic traumatic encephalopathy, which you hear about in football players, mainly contact sports, right? Punch drunk, think Muhammad Ali. And then I'll talk about reversible causes, which is very important to know, because there is reversible dementia. And then we'll talk about something called mild cognitive impairment. Actually, I'll start with MCI. So I can touch a little bit on normal aging and cognition, and then beyond that, mild cognitive impairment, and then beyond that is dementia, which is actually a neurodegenerative process of the brain. What does that mean? There's shrinkage or atrophy of the brain. Remember, shrinkage or atrophy of the brain happens in everybody, but it progresses at different rates. Usually in your 30s, the shrinkage is 5% a year or something. But if you have a disease like MS or other brain diseases, the shrinkage is faster, or Alzheimer's, the shrinkage of the brain is faster. That's what you read on your report as atrophy. All right, so having said that, what is, let me play my slide. So you can see, you guys see my slide, right?
Yes.
Yes.
A lot of people ask me, how do I know? I have memory loss. How do I know whether it's age-related or it's a problem? It's a pathology, right? There is some slowing of memory with age, especially taking in new information. So registration and recall can be slowed down. But there's no wipeout of, it doesn't get wiped out. So that's the, and one thing I have noticed very commonly with in cognitive changes with aging is word finding, name finding difficulty. I know the face, I can't remember the name. I know this is a pen, but I don't remember the name. Then you go from, say, subtle changes, cognitive with aging, you go to this condition called MCI, like the telephone company in the old days, mild cognitive impairment. So it's a stage of cognitive loss between normal aging and dementia, defined mainly as more than expected for age. But it does not meet criteria for dementia. We will talk about that. What is dementia then? Memory problems come with aging. This is the prevalence by age. You can see after 60, it's about 6.7% per year, and over 80, 25%. It's pretty high, actually. So age is a risk factor for memory loss, among other things. Now, memory loss more than expected for age, called MCI, was thought to be a precursor to AD, and still maybe. It's mainly of two types: amnestic, as in you don't remember information, memory loss, or it can be non-amnestic, where you have problems with language, with visuospatial skill, like finding things, where did you put stuff? Executive function, for example, this is the tax season, doing my taxes, putting things together for that. So there are two main types. Memory loss or cognitive loss doesn't only have to be memory, because cognition is not only defined as memory, it's defined as many subparts, of which language is a skill, executive function, insight into, a lot of people with advanced memory problems do not even realize they have a problem. So they lose the insight, visuospatial skills. What do we look for? We have to have a family member corroborate the information. Otherwise, because I will tell you, almost every person that I see has dementia says, no, they don't have any memory problems. Because that is what the definition is. They do not realize that they have a problem. So they'll actually get very upset and fight you. So it's very important for family and people, the warriors out there, if you know you have memory loss and it's affecting you, it's probably not dementia. Because if it was, or at least it's not early, you would not be aware of the deficits. Remember, memory is always judged against age. And the second thing is level of education. We do know that higher education is a preventative factor for dementia. More important, it is change in your baseline function. So look at the last point here. Memory impairment that qualify for MCI is actually standard deviation from normal. So it's more importantly, we are looking at a change. And generally, cognitive function is preserved and you're able to function, so you can go drive, go to your social hour, really no problems. Doesn't meet criteria for. The other thing is very important to know. This early stage of memory loss is not irreversible. It can be reversed. And there are reversible causes. That's why it's important. And we'll get into more of these things, but there is depression, for example, causes memory loss that looks like dementia. We call it pseudodementia. It's irreversible, not irreversible. It is reversible. Medications, some what we call anticholinergic, for example, some older antidepressants, some older antihistaminics. Example, what does that mean? Benadryl, for example, is an antihistamine, anticholinergic drug that can cause memory loss. So don't overuse it. Be careful what you use. Not all MCI leads to AD, 5 to 6% per year per a Mayo study. But remember, it can be reversed if the inciting factor is taken away. For what do I mean? If depression is treated, if the meds that are causing it. I very often will see seniors on benzodiazepines, drugs like Valium. They cause this kind of issue. So we'd say you're probably better off getting off this medicine if you want to feel better. All right, so other reasons for MCI or mild cognitive impairment can be educational level. Vascular risk factors, what do I mean by that? I have seen repeatedly, and I want to emphasize this point, obesity as a cause for memory loss. I have seen people with MRIs in their 40s whose brain look like they're in their 60s, just from obesity. Obesity accelerates atrophy of the brain, causes a lot of issues. So weight is very important, and we'll get into diet and exercise a lot later on. High blood pressure, diabetes, heart disease, stroke. Then there are some genetic factors. I'll touch a little more on this later on. Remember, the genetic causes for dementia are very rare. They're not the most common. 60 to 80%, you don't have genetic causes, direct genetic cause. And these are just some of the symptoms, neuropsychiatric symptoms. Okay, busy slide, but I talked about MCI being associated with neurodegenerative dementias, vascular dementia. I'll talk a little later more about this. Vascular dementia means dementia due to stroke. Psychiatric illness, I touched on depression causing pseudodementia, not real dementia. Medications, I touched on a few. I'll give you an example of Valium-like drugs or Benadryl-like drugs. Very important, last point, remember, people that drink alcohol in excess, it drops your vitamin B12, vitamin B1 levels, causes cognitive and memory loss, can look like dementia, but it's not dementia. So there's an example of reversible cause. If somebody's an alcoholic, we warn them, hey, you got to cut back if you want your memory to be preserved. Okay, so
Can I interrupt 1 second, Doctor? I'm sorry, because
Yeah.
we're talking about causes and there's a question that relates to that. Can arthritis have an effect on memory loss?
Not really, not directly, but indirectly I will, because physical activity becomes a part.
Okay. Thank you.
When we talk about prevention, physical activity, you'll see that number one. So lack of that does cause cognitive. Lack of that, isolation. All our patients were worse in the pandemic because they didn't see anybody. And dementia got worse. This has been documented. All right, let's see. Now, this is the $1 million thing, right? What is age-associated and what is normal? And I touched a little bit on it. Age-associated cognitive impairment happens. It's that difficulty, registering and keeping in new information. Your response time slows down, but you're still able to function. You may misplace your keys now and then, but you will routinely find it. But if you cannot and becomes a pattern, we leave the stove on and you don't even know about it, that's not age-related. That's a problem. Okay. As I said, it's a change in baseline level of cognition, which is what is more worrisome, and families pick that up more than the patient. And at this stage, most patients are aware that there's something not right. Okay, so the next slide, this is where we go into Alzheimer's dementia. It is the most common form of dementia. LOAD means late onset Alzheimer's dementia. Most of dementia is late onset. What does that mean? After age 65. Before age 65, it's called early onset. Then you may ask me, what is dementia? Dementia is not just memory loss, but cognitive impairment that affects your ability to function on your own independently. You can't be trusted to drive because you get lost. You've had motor vehicle accidents, you're hitting the curb and you don't even realize it, right? You're not reliable enough to send out bills or manage you're overdrafting your bank because you don't remember, things like that. Those are just some examples. Generally people are able to feed themselves, get dressed till later on, but not being aware. So I add another thing to this definition is not being aware of your deficits as it progresses. It's a common disorder. I mean, I put a number here, about 6 million Americans affected, numbers expected to triple by 2050. Most of that is driven by our aging population, number one. Number two, also by these vascular risk factors. So what are those? Heart disease, diabetes, stroke, hypertension, obesity, peripheral vascular disease, cholesterol problems. So those need to be treated. Traumatic brain injury, just happening out there, either related to sports or falls, they add up, they increase your dementia risk. Poor sleep, this is very important because this is potentially preventable and reversible. When you sleep, especially in your deep sleep, your brain has this system called the lymphatic system where it removes waste. That's the only time it does it. I tell people, think of it as an automobile. When the automobile is running, you need a carburetor or something to remove the waste product. Otherwise, your car is not going to run. So when the brain is working, the cells are working, they're producing waste product. What happens to that? It has to be removed. Otherwise, it'll accumulate and cause problems. So that is what happens in your deep sleep. Your lymphatic system removes that waste. What if you never went into deep sleep? You have poor sleep. What if you have sleep apnea? Very important, high risk of dementia and sleep apnea. In sleep apnea, your brain really never fully sleeps because it's not getting oxygen. So that is a big risk factor for dementia. Years of education are preventative, actually, and greater physical and cognitive activity, so lower risk. What does that mean? Gainful employment, cognitive activity. Why? Because when you're employed, you're forced to use your brain as opposed to otherwise. Greater physical activity, people doing mental stuff, right? Some people do crosswords and Sudoku and stuff like that, online games. Is there one specific one over the other? No. Is there very strong data to show that all of it helps? I think in unison, taken together, it helps, but just by itself, it doesn't. A lot of people have this gene called ApoE. If you carry that, you're high risk of having dementias. There are other inheritable risk factors for dementia, and we'll touch on that a little bit. And this Alzheimer's generally presents with gradual progressive decline in memory. So remember, I told you about episodic memory, working memory, semantic, prospective. So remembering events, things like that becomes harder. So gradual progressive decline, as opposed to early onset dementia, which is onset before age 65. Really a small number of cases. We think these people have a larger genetic predisposition. I put in the bottom bullet in there some of the genes that are associated with. Now there's a difference here. I don't want to confuse this. Early onset is different from familial. They may have familial is, you have these genes and you're going to get it. That is less than 1% of Alzheimer's cases. Less than 1% are familial. I get this question all the time when I see people. What's the risk that my children are going to get it? If you don't carry the gene and they don't carry the gene, then the risk is less than 1%. But by far majority is late onset, what we call sporadic dementia. There is early onset, there's inherited forms. They vary a little bit in their presentation. The early onset are more aggressive. They have more language impairment, more psychological difficulties. They look a little different on testing like MRI, PETs, and neuropathology. Treatment is the same so far. And the treatment brings up a couple of important things. So in the 90s, 1993, there were 3 medicines. We still use them. These are called cholinesterase inhibitors. They're still around. They are modest at best. So people will still see progression. Benefits are modest. Why do we use them then? Because some of them also help behavior. As this problem progresses, behavior becomes an issue where people get agitated, irritable. They may get apathetic on the other end, not want to do stuff. So that's still, those can help. But in the last 2 years, we've had 2 new medicines, now 2, that we call anti-amyloid drugs. So for decades, it was thought that Alzheimer's happens because this protein in our brain, you and I, everybody has it. We need it for normal functioning, called amyloid. Something happens to amyloid and it starts accumulating in your brain. And if it cannot be cleared out, it causes what we call amyloid plaques, and that leads to dementia. That was one theory. There's many theories. Based on that, people devised these treatments that remove amyloid from your brain. For example, a drug called Aduhelm was approved more than a year ago. There was a lot of controversy about that because the researchers did not show any clinical benefit, as in the person that's getting it improving from it, but their scans got a lot better. So it cleared the amyloid, but did it improve the situation on the ground? Maybe marginally. And then it had some unique side effects, including swelling in the brain, bleeding in the brain. And it was, when it came out, $56,000 a year or so. After a lot of protest, it was put into, now it can only be prescribed in a clinical trial situation where they are running phase 3 trials. And a similar drug has been approved last month, actually, called lecanemab, which in fact has shown clinical benefit. It has shown not only it clears the amyloid in your brain, but it also improves cognition and memory modestly. So we do have some new treatments in the pipeline. I actually believe that the person that's going to be cured, not treated, cured of Alzheimer's has been born. And the research is going in that direction. Okay, so that's about Alzheimer's. We'll switch gears and go into, this is called FTD, or frontotemporal dementia. This is what you heard in the news this week that Bruce Willis has been diagnosed with. It is a type of dementia where it's actually the second most common. So there's a debate going on which is most common. Maybe Alzheimer's most common, FTD, vascular Alzheimer's, FTD second. The difference is this one doesn't present classically with memory loss. It presents with dysfunction or decline in social and emotional function. What is it? I'll give you an example. Grandpa is traveling in a bus and makes inappropriate jokes. This has become a pattern. It's becoming a problem for us. People are complaining. That's not uncommon with behavioral frontotemporal dementia. Difficulty controlling their emotions. They also have some motor deficits that start, tremor, weakness, stuff like that. Memory losses comes later on. And treatment, so far, non-pharmacological approaches, because behavior becomes an issue in this, where they get agitated, aggressive, they can be psychosis. They can be compulsive, they can overeat. That's a feature of this disease. So it's actually a syndrome. A syndrome is a collection of signs and symptoms as opposed to a particular disease, which is different. All right, so that's, let's keep an eye on time to let me know if I need to stop. Lewy body dementia. More and more we are being asked about Lewy body dementia because it's in the press. Parkinson's disease, we see a lot of Parkinson's. If somebody has Parkinson's and they get features of dementia, it can be Lewy body, but the onset time is different. But remember, if somebody looks like Parkinson's and also has dementia, could be Lewy body. Or Parkinson itself has dementia associated with it, which comes after symptoms of Parkinson's. This one, Lewy body dementia, has some. Lewy body is actually found in neuropathology, in neurons, on autopsy, hence the name Lewy body. That's what it is. But it's a dementia with features of Parkinson's and dementia together. And they present differently. Early on, they have difficulty with attention. Memory is later on. And this fluctuates. So core features are, one day they are much better, another day they're not. They hallucinate, see things that are not there. I said they can be Parkinsonian. I put RBD there. This is important. We're seeing more and more people who come. What is my risk of Parkinson's? Because I've been told I have RBD. What is RBD? RBD is REM sleep behavior disorder. Sleep is mainly of two types, REM, non-REM, and deep sleep. Non-REM sleep, REM sleep is when you dream. And when you're dreaming, the muscles in your body are generally paralyzed, so you don't act your dreams out. We call that muscle atonia. When that tone is there and you're dreaming, then you start acting, fighting, hitting your bed partner, things like that. So these people start acting. Most common dream in REM sleep behavior disorder is they feel like they're being attacked and they start fighting back. And people with RBD are at very high risk later on to get Parkinson's. And so this is a very common feature with Lewy body disease. How do you treat this? You can use the same drugs as Alzheimer's, but specifically in this situation, you have to avoid certain drugs like Haldol or older antipsychotics because it'll make them worse. And they also have very high risk of falling, passing out, having constipation, dry eyes, sleeping too much, apathy, things like that. Vascular cognitive impairment or vascular dementia, important to know. This is actually very common. It is different from Alzheimer's dementia. In this case, it's usually associated with, say, a heart attack or a stroke or what we call a TIA or mini stroke, where strokes can be clinical, as in, you had a stroke, and many of you may have heard, oh, my doctor told me I had stroke on my MRI, so silent strokes. Important thing to know, I told you Alzheimer's starts and gradually declines. Vascular cognitive impairment, if you go by definition, starts, then there's stepwise deterioration. Then they plateau, stepwise plateau. Why is that? So they're going down. Something happens. What is that something? May have had a stroke that you're not aware of. And there's a rapid decline. And then they stabilize at their lower level. Then something happens again. So it's important, if that is the pattern where you are good, maybe having some memory problems, all of a sudden you got worse. And there's no other reason for it. So you got to get yourself checked out, make sure you don't have a stroke. The treatment of this, you got to treat the underlying cause, like stroke, chronic traumatic encephalopathy, punch drunkenness, it's been called in the past, or dementia pugilistica. I told you, think about Muhammad Ali. More recently, this applies to our football players. Not only football, it applies to soccer players. It applies to our military veterans. This is a type of dementia which is due to repetitive, so not one. Remember that. One head injury is not going to lead to dementia. Repeated head injuries, concussive or subconcussive, can lead to this new condition called CTE. You may have heard about these cases where these NFL players, they get homicidal and kill people. And then their family has an autopsy run on their brain, and this is what shows up. You'll be surprised that number 2 bulletin, there was meds and colleagues. So this is mainly right now, there are no biomarkers that can diagnose this when a person is alive. These are all from brain banks. People have died and they've donated their brains. 99% in this sample of NFL players that were sampled had changes of CTE on their brain. So how does it progress? It presents with progressive cognitive decline. Behavioral, remember, they get irritable, upset, angry, mood changes, anxious, depressed, and memory deficits. So memory deficits are not only just pure memory, it can be executive, attention, concentration, depression, out of control physically, verbally, impulse control problems, suicidal ideation. And the differential DDX there means differential is you also look at frontotemporal dementia. I told you frontotemporal dementia, people have behavioral changes before Alzheimer's. AD there stands for Alzheimer's dementia. All right, let's talk about reversible causes. Why? Because reversible means we can reverse the dementia. So you must be thinking, whoa, I never knew about that. You can reverse dementia. Yes, depends on the type. Toxic metabolic causes. What do I mean? Classic example is alcohol, drugs. You get off those, there's a chance, if it's not gone too far, that you will get better. Medications, I give you one example of Benadryl and Valium. Sleep disorder. Deprive someone of sleep, they look like they're demented. They really not are, but they will. Psychiatric illness, we talked about. Depression, looking like pseudo-dementia. That's why I call it pseudo-dementia. Other causes like infection of the brain called autoimmune encephalitis or syphilis in parts of the world or country where syphilis is prevalent, it's routinely checked for. NPH means normal pressure hydrocephalus. This is why you hear about people kind of telling you, I have too much water on my brain. So this is potentially treatable. How do they present? They have memory loss. They have walking or balance abnormality, and they have urinary incontinence. And you scan the brain and you see that the atrophy is, and the brain, so the brain, inside the brain, there are ventricles, which are like hollow spaces. They are larger than normally expected. And you can actually do a spinal tap, remove some fluid, and they get better. And that's how, then you put a shunt in the brain and they get better. We have several people that haven't gone too far, actually reverse and go on to have a normal life with this problem. Okay, so how do you keep your brain healthy, right? Everybody wants to keep their brain healthy. I tell everybody, if I have to write one prescription, provided you have a healthy lifestyle, as in you're not drinking too much alcohol. I get asked about weed. Weed is a different topic. It's not preventative. It doesn't help dementia. By the way, let me get that out of the way. Physical exercise would be the top prescription I would write. Why physical exercise? When you exercise, you secrete many hormones or chemicals in your brain, one of them called brain-derived growth factor, that actually enhances your nerve cells, enhances the connection between them. Also, a lot of it comes from cardiovascular benefit. What is good for the heart is good for the brain. Your loss of cognition slows, your brain atrophy slows with exercise. How much exercise? Generally, we say 150 minutes a week, so 30 minutes a day. What type? Any exercise is better than none. Even gardening is better than none. But if you really want to get that real benefit, you have to get your heart rate up. So cardiovascular, aerobic. And then second thing on that list is diet. Heart healthy diet. Heart healthy diet, or the mind diet. If you want to write the word mind, it's a combination of Mediterranean and diet against hypertension. Basically, more grains. And recently, you guys, a lot of you must have read, processed food increases risk of dementia by over 20%. Ultra processed food, I should say. I have more recently been following a very important thing that I read. If you pick up something in the store and it has more than 5 ingredients in it, don't even buy it. That means that they had to process it really for those that, and if it has a shelf life of 6 to 12 months, just think in your head, how does it have that long shelf life? They put stuff in it for it to have that long shelf life. So whole grains, green leafy vegetables, berries, less red meat, chicken and fish, okay. Beans, nuts, avoid fried foods, use olive oil for cooking, limit your salt and sugar intake. A glass of wine is fine, but nothing in excess. So that's what you want to be doing for your diet, mainly. 2 things if you want to take away to improve your brain function: physical exercise and diet consistently. Not just today we did it, not again. 3rd thing, memory consolidation happens. Brain is restored. Toxic proteins are cleared when you are sleeping. You have to devote 7 to 9 hours of quality sleep. Quality sleep is the thing. You have to get into that deep sleep. Don't use your phone. Don't drink caffeine, alcohol late in the day. Minimize screen time late in the day. Those things will help your quality of sleep. OSA stands for obstructive sleep apnea, hugely underdiagnosed. Big risk factor for dementia, heart attack, stroke, motor vehicle accidents, obesity, name it, directly related to sleep. And presents usually, bed partner would say that he snores a lot, or we see them breathe and then stop. So that's called apnea, apneic spell. So got to get that checked out. And improves your quality of life once it's diagnosed and treated. I talked a little bit about mental exercise, like do new things. Do a variety of things, like attend a lecture at the library, like you're doing right now. But yeah, you can do Sudoku, puzzles, but do different things. Learning a language, learning a new instrument, music, maybe the best thing you can do for your brain, actually. Stress reduction, you can do whatever you want to do. There's many ways to do it. You just have to do it. Deep breathing, Tai Chi, meditate, yoga, mindfulness. If you YouTube mindfulness, you'll find so many things on there. Just pick what you do. And yes, spiritual fitness, staying active in the community, church. I told you a lot of our folks got worse in the pandemic because they were cooped up in the house. They didn't have that socialization that you get from other people, the benefit of that. I think that is it. That's all I have. That was my last slide. So I can answer some questions if there are.
Okay, if people want to put some questions in the chat, I'm going to start with one that I kind of came in with as the big one for me. Is there any evidence or fact that brain or memory supplements or vitamins or minerals have any effect? I'm tired of the commercials. I want them to stop.
Nutraceuticals. What you're talking about, those are called nutraceuticals. Almost no evidence in rigorous clinical studies. They have been designed a lot based on their biological properties. People take them because somebody felt a benefit, this and that. But they haven't panned out in rigorous clinical benefits. So the answer is, the example is I get asked repeatedly, should I take Prevagen? And I've asked people how much does it cost? And it's over $50 for a bottle is what I've been told. And so I personally don't recommend them. The other problem with these supplements is they can hurt you too, right? You don't know what the fillers are in them, and really they're not regulated. So it's not only lack of benefit, but potential side effects and risk. I'll give you an example. When I was in training 20 years ago, we saw dementia. We routinely put people on vitamin E. Then with studies, we found out vitamin E in excess increases risk of death. So guess what? We don't do that anymore.
Okay. Any other questions, Chad, or if you just want to open up your mic?
Anybody out there have anything?
Please don't tell me you forgot your questions.
I guess I was surprised by if I understood you correctly, the lack of a genetic connection with Alzheimer's or dementia. I don't know if you could expound on that.
Yeah.
In my family.
So there is familial AD, which, for example, the genes are presenilin 1, 2, ApoE, APP. That is less than 1%. Most of the dementia we see, I should be careful about framing this. So is it inherited? So this is actually true for many diseases that we see in neurology. Why did I get it? My brother didn't get it. Things like that. So there is a risk. If there's a family history, there's a risk. But the majority form of dementia, there is no direct, you cannot point one gene to it. Could there be polygenes or multiple genes that we are not aware of? Yes. I think you have to have susceptibility to the disease, which could be family history, but environmental factors play in too. What do I mean? Environmental factors like TBI, vascular risk factors, substances that play into it.
Okay. There's a couple more questions. One is, and I assume this means like the vitamin E's, are there other treatments that were being done regularly that are also not being done now?
Oh yeah, we used to put people on estrogen too, ladies, for memory years ago. We don't do that anymore.
Okay. And then there's another question. Does the brain continue to improve if you continue the prevention techniques, or does it plateau at some point?
So I'll answer this a different way. So there is this theory of plasticity, right? The brain is like a plastic organ. It continues to get better. Why does that happen? So I'll give you an example. If somebody has a stroke, stroke means loss or death of nerve cells to that area. So typical presentation with stroke is paralysis on one side. But how do people get better then if that brain area is gone? That's where plasticity comes in. The adjoining areas take over. We think more than nerve cells, the synapses where the nerves talk to each other and information is transferred may be more important. Because, you have billions of neurons, 80 billion, some people say 100 billion. With one stroke, every minute you're losing 100 million neurons. And the neurons you don't really keep regenerating, but you have to the power of 10 synapses where they talk. But the synapses can sprout, learn new information, spread it. And so by that mechanism, yes, the brain has the ability to keep learning if you make it learn. That is why we send you to therapy, physical therapy, occupational therapy, speech therapy. Why? Because we want to stimulate those parts of the brain to learn information that has been taken away or put new information.
Okay. There's a couple more questions that are the two of them are related. You had talked about B12 deficiency. Is B12 beneficial as prevention? And also, what about vitamin D?
Unless you're deficient in it, no, neither. So a lot of people take vitamins, and we were all on the vitamin D train till recently, even a lot of doctors, because everybody says take vitamin D. Then a study came out last year, I like a large study, and said, if you're not deficient, there's no point in taking vitamin D. I routinely prescribe vitamin D for some health issues like MS. I will say vitamin D is important. Vitamin D, not just for bone health, for other nerve health too. But is there evidence to show that if you have no deficiency and you take these vitamins that you will gain? No, unfortunately not.
Okay. Any other questions from anyone?
I think, Shelley, at some point you had a hand up. Do you have a question?
I was just wondering, years ago, I was told that my grandmother's dementia was due to hardening of the arteries, and I was wondering if that was the vascular cognitive impairment you were talking about. If that's the same.
Yes, sort of. Arteriosclerosis is what it's called. Arteriosclerosis. You may have gone to your doctor, you had a brain MRI, and they say, oh, you got white spots in your brain. Or you had an MRI, they told you white spots in the brain, and everybody gets very nervous. Arteriosclerosis is something that happens with aging. Our blood vessels are pulsatile. As we age, they become less pulsatile, they harden. That's why blood pressure, hypertension, blood pressure happens, plaques and all that. And so that can lead to what I said about silent strokes or white matter disease in the brain or white matter load. And that is a risk factor for dementia. Yes, it does lead to dementia. Vascular cause.
Okay, thank you.
At some point, I don't think you can put Alzheimer's in one pot and say this is purely just degeneration of the brain. And then vascular, this is just blood vessel. And then Parkinson, it's only dopamine deficiency. I think as these things happen multifactorial. Remember, that's why physical activity also helps Alzheimer's prevention, because again, blood vessels, so neurodegeneration, vascular disease, other things, mitochondrial dysfunction, all of these contribute to Alzheimer's dementia. Mitochondria are your powerhouse in your cells.
Are there specific tests to find out if you're deficient in a vitamin?
Yeah. There's blood tests, easily detectable.
Okay. You just have to say you want to make sure the blood tests for either vitamin D or vitamin B12.
Yeah. Yep.
Okay. There's one other question posted. Do you have a recommendation on when is the best time to have potential dementia checked, a particular sign or some event that or occurrence in your life or an age that might be the best time to check it out?
So 65 and older risk for Alzheimer's highest. When do you check it? When usually it'll be family members. When they start noticing things that, yeah, you left your wallet at home and you've done that 2-3 times already, right? And you're driving around, or you're going from Wakarusa to KU and you've done that for 20 years and you get on 6th Street or Iowa and you don't know how to get to KU. Things like that, repeated deficits.
So are there any promising like developments out there for,
Oh
addressing?
yeah, a lot. I mean, I talked briefly about 2 drugs,
Mhm.
these anti-amyloid drugs. So the improvements are not only in therapeutics, but they're also in testing. As in, there are blood tests where you can check, they're not available clinically yet. What is the level of amyloid? What is the ratio of amyloid versus, I haven't even talked about tau, which is another problem, tau tangles, which are abnormal kind of proteins in the brain that go haywire in Alzheimer's. Those can be measured in your blood, in your CSF, and you can predict whether this is going to go to Alzheimer's or not. Those will be available. So testing, therapeutics, interventions, not only medicines, or yes, there is a lot of movement on this front.
Yeah, it looks like there's another question. Is it good to have a baseline test done when you notice small changes or can't remember threads of a conversation?
I would say yes. So one of the things we use is something called neuropsychological testing. It is like a half a day of battery of tests of cognition, memory, language, insight, executive function, attention, mood. I'll give you an example. I repeatedly see young people in their 30s and 40s, I have memory loss. And I ask them, are you depressed? No. Do you have attention deficit? Maybe. Remember, if you cannot pay attention to something, how are you going to take that information in? How are you going to store it? And how are you going to retrieve it? So that's a major thing that we always have our antennas up for, is there's just we treat ADD, attention deficit, and memory gets better. That's one of those reversible causes I told you. If there's something that's been bothering you and or your family member, and it's not still inhibiting your ability to function, yeah, you need to be tested early, because remember, these couple of drugs I told you, they're only approved for mild cognitive impairment and early dementia. So yes, there is very promising treatment.
Looks like Mary, do you have a question? You need to unmute. There you go.
Okay, very good. Well, just someone who has always seemed to be in control of their driving and know where they're going and what they're doing. And then all of a sudden you start noticing they're talking about that they're going to go to a specific spot, and within 5 minutes they have forgotten and driven by it. And you're starting to see this more often. Is that?
That's a problem.
Mm.
That's a sign of something more.
Mhm.
That's part of that executive function, right? I mean, ability to do stuffs.
Mm-hmm. And on the another piece of that is I was unfortunately unable to get into this site for the workshop in the very beginning. Did you at any point mention a connection between loss of hearing?
Oh, no, but good thing you pointed that out. Excellent question. Yes. Loss of hearing, folks, is a risk factor for dementia, not just memory loss. Remember what I told you about attention? If you cannot take information in, you won't store it and retrieve it. So your memory will be affected. Yes. And a lot of people resist wearing hearing aids because they don't like them, just like they don't like their mask for sleep apnea. But those things you should be trying to use as much as possible.
Thank you.
Okay, do we have time for one more? You mentioned sleep deprivation as an issue for the future. Can sleep deprivation mask or appear like dementia when in reality the person just needs more sleep?
Yes, absolutely.
Okay, and then there was one question about a specific slide you had, and I know it's getting kind of late. Rather than go back and try to find that slide, it was about. Hang on, let me see if I can find it. Would you please share the slide showing age-related decreases again? We could do that, or if we have your permission, can we share your slide presentation after the meeting and then?
Yeah, no problem.
Okay, great. we can do
Okay,
that.
maybe that would be easier because we're getting near the end and there may be a few other questions, but I'll send out an email to everyone with the actual slide presentation and PowerPoint on.
And we can include the recording as well.
Okay.
All right.
I'll have to learn how to do that part.
We got that covered. Don't worry.
Okay. Kathleen will do that. Says
No,
the new
Logan will
guy.
do that.
All right.
So, all right. Well, I think we're bumping up on 5 o'clock. Oh, Shelley, do you have a quick question?
I was just wondering, for those of us who live alone, is it helpful to go in and get a baseline cognitive test so that, because we don't have family members who will notice any diminishment in our capacity. So could we get some sort of a baseline test that we can compare 5 years from now or 10 years from now or whatever? Or is
Yeah,
that just
good
silly?
question. The tests are not, the baseline tests are, I should be careful of. They're not, if somebody is abnormal, do they have dementia? No, they don't. They're not very sensitive or specific. They're good. They're good for screening. The American Academy of Neurology has not recommended baseline screening for dementia. So,
Okay.
because we don't have a perfect test yet for screening. But I hear what you're saying. Yes, I mean, it's easy to get tested. If you want to get tested, it's easy. Your doctor can do that. We can do that. Most of it, a lot of times I'll see the warriors and I'll talk to them and I say, hey, I think you're just more worried than anything else. Why don't we just meet in a year unless you have something come up? And a lot of people are fine with that.
Okay, thank you.
That's part of the evaluation too, right? I mean,
I think we're getting near the time we've had. It's been tremendous. A lot of information and a lot of kind of very difficult and hard to take in. So it will be posted on YouTube. We'll send out the information as well. And I wanted to thank everybody. I also wanted to share that, you know, the exercise part of it, I see a lot of folks our age at Rock Chalk, and also wanted to mention that LMH has programs out there that are available for seniors specifically at Rock Chalk. So, you know, I'll just kind of put that note in there as well. And some of our members I've seen at that activity as well. So I'll just pass it on. And once again, thank Allison and the doctor for a wonderful evening this evening. And you can unmute and applaud, but thank you very much. Appreciate it very much.
thank you. Bye, guys.
Thank you very much, Doctor.
Thank you.
Thank you.
Okay.